So, if you take a person who is clinically obese, their risk of developing osteoarthritis in their knees and hips goes up significantly.
Right, which, makes perfect sense mechanically.
Exactly. I mean, there is just more physical weight bearing down on those joints.
Yeah.
But here is the piece of data from our sources today that just it doesn't make intuitive sense at all. That same person's risk of developing osteoarthritis in their hands goes up too.
Oh, yeah. It's wild.
And your hands aren't carrying your body weight.
No, they aren't. It completely breaks that conventional logic of how we think our bodies wear down. We just assume joint degeneration is this simple math equation of gravity and time.
Like tires wearing out.
Exactly, like
Yeah.
tires. But that hand arthritis data tells us something much more complex is happening chemically.
Right. And today we're going to explore how your own body fat might actually be waging a kind of chemical war on your skeleton.
It's a fascinating pivot in how we view the body.
It really is. So we're looking at a stack of sources today to do a deep dive into reading bone and joint diagnoses. Specifically, our mission is to pull apart two of the most commonly searched yet fundamentally conflated musculoskeletal terms out there, osteoporosis and arthritis.
Yes, because if you ask, like, a room full of adults to define them, you usually get this vague cloud of just old person joint problem.
Right. Aches, pains, losing a bit of height.
But clinically, I mean, these are radically different processes.
Which is why decoding these diagnoses matters so much for you listening. As you age, knowing the mechanism of what is happening inside your structural scaffolding versus what is happening inside your joints, well, it dictates how you maintain your independence.
Truly, treating a joint inflammation problem, like a bone density problem, or vice versa, leaves you completely vulnerable to the other one.
Let's start with the bone itself then, and I want to jump straight into the cellular level because our sources dismantle this idea that your skeleton is just, a rigid, static frame of calcium,
Oh, it's not static at all. It's actually a never-ending construction site.
a very chaotic one.
Highly chaotic.
Yeah.
Bone is a living tissue undergoing this constant churn, a process called remodeling.
Mm.
So on one side, you have the demolition crew, these cells called osteoclasts,
Osteoclasts with a C.
right? And they literally attach to old bone, secrete acids to dissolve the minerals, and then release enzymes to digest the protein matrix. They're actively eating your skeleton.
Which sounds terrifying, but it's normal.
Totally normal, because trailing right behind them are the builders, the osteoblasts, with a B.
Okay, builders with a B, demolition with a C. Got it.
Exactly. And the osteoblasts just fill in those excavated pits with fresh matrix and minerals.
Okay, let's unpack this for a second. If the demolition crew and the builders are working at the exact same speed, you maintain your bone density.
Precisely.
So osteoporosis must be what happens when that rhythm just breaks down.
Right. The breakdown outpaces the rebuilding. The osteoclasts start working overtime, and the builders simply can't fill the holes fast enough.
And for women, the sources highlight a very specific trigger for this imbalance, which is menopause.
Yeah, because of the massive drop in estrogen.
But, I mean, how does a hormone control a bone cell?
Well, think of estrogen as the site foreman, right?
Mhm.
And the foreman's main job is to restrain that demolition crew. Estrogen actually limits the lifespan of osteoclasts and keeps their numbers in check.
Oh, wow.
So when estrogen levels plummet during menopause, the foreman basically leaves the site.
Then the crew goes wild.
Exactly.
Oh.
The osteoclasts live longer, they work more aggressively, and they run comparatively unchecked. So a woman can lose a massive percentage of her bone density in just the several years immediately surrounding menopause.
Just because that chemical restraint is gone.
Yep.
Wait, I need to stop you there. Because if a huge percentage of my skeleton is being actively dissolved by my own cells, I feel like my body should be sounding alarms. How does a person not feel their bones thinning out from the inside?
That is the most insidious characteristic of osteoporosis.
Yeah.
It is completely silent, totally silent. It is a disease of bone quantity, and losing that quantity produces zero pain, zero swelling, zero stiffness. You don't feel the structural integrity failing.
So how do you know?
Well, the very first symptom is almost always the structural failure itself, a fragility
A
fracture.
fragility fracture. And we aren't talking about traumatic injuries here, right? Like a car crash.
No, yeah.
The sources define a fragility fracture as breaking a bone from a fall from standing height or less.
Right, or even less than that, like bending over to pick up a laundry basket,
Jeez.
or a coughing fit that snaps a rib.
Or I think one source mentioned stepping off a curb and shattering an ankle.
Yeah, it takes almost no force,
Yeah.
and the ones that often go entirely unnoticed are vertebral compression fractures.
In the spine.
Right. The trabecular bone, which is the spongy network inside your spinal vertebrae, it thins out so much that the bone literally crushes inward under the weight of your own torso.
Just from gravity. And because the disease is silent, people might just write that off as a bad backache.
Oh, many do. They assume losing a few inches of height or developing a stooped posture is just, inevitable aging.
Right.
They only discover the vertebrae have collapsed when they get an X-ray for something else entirely, maybe years later.
But hip fractures, that's where the silent nature of the disease becomes, well, fatal.
Yeah. The mortality risk in the year following a hip fracture for an older adult is staggeringly high, mostly due to the complications of prolonged immobility, like blood clots and pneumonia.
Which brings up a critical point about diagnostics. If it's silent until it shatters, you'd think your annual physical would catch it, like with a standard X-ray.
You would think so.
But the sources point out a terrifying limitation there. An X-ray won't reliably show bone loss until you have already lost a massive 30% of your total bone mass.
30%. You could be missing nearly a third of your structural scaffolding, and the radiologist looking at a standard chest or hip X-ray might literally note that your bones look completely unremarkable.
That is wild. We're going to get into how we actually measure that invisible loss in a moment. But first, if osteoporosis is a silent loss of structural quantity, what happens when the connections between those bones, the joints themselves, start breaking down? Because arthritis is famously loud.
Oh, very loud, and announced this very early. But, and this is key, arthritis is actually a notoriously frustrating medical term because it isn't one disease.
Right.
It's a diagnostic umbrella covering over 100 different conditions that cause joint inflammation.
Okay, so to really decode it, we need to focus on the two heavyweights from our sources: osteoarthritis, or OA, and rheumatoid arthritis, or RA.
Let's tackle osteoarthritis first.
Yeah, because the conventional wisdom I grew up with is the brake pad analogy.
Ah, yes, the brake pad.
Right, like your cartilage is this rubbery gasket between your bones, and over decades of walking and running, you just mechanically wear the gasket thin until it's bone scraping on bone.
Well, modern rheumatology has completely dismantled that brake pad myth. Yeah. Work from leading epidemiologists frames osteoarthritis as an active whole joint biological disease, not just physical friction.
So it's not just wearing out from use.
No. The cartilage doesn't just passively abrade, it actively degrades through enzymatic breakdown. Furthermore, the bone sitting right underneath the cartilage, the subchondral bone, it starts remodeling itself abnormally in response to the stress.
Oh, so the bone gets involved too.
Yes, the joint starts growing bony spurs, called osteophytes, to try and stabilize itself.
Okay, this brings us right back to that bizarre fact from the beginning of the deep dive. The hands.
The hand arthritis.
Right. If osteoarthritis is an active biological disease rather than just a mechanical wear and tear issue, that perfectly explains why obesity increases the risk of osteoarthritis in your fingers.
Exactly. And the distinction comes down to what fat actually is.
Right.
We used to think of adipose tissue body fat as inert, passive energy storage, just dead weight.
Just extra load on the joints.
Right. But it turns out fat is an active organ. It continuously secretes inflammatory signaling molecules called adipokines.
Adipokines. So these adipokines are basically traveling through the bloodstream, reaching the hands, and chemically promoting the degeneration of those joints.
Precisely. Obesity drives osteoarthritis systemically through these inflammatory chemicals, in addition to the local mechanical stress on the knees and hips.
Wow.
Your body fat is actively participating in the degradation of your cartilage.
That completely flips the narrative. I mean, it changes how you view a few extra pounds. It's not just a load on the frame, it's an active chemical contributor.
Exactly.
Now, if osteoarthritis involves fat tissue sending rogue inflammatory signals, what happens with rheumatoid arthritis? Because the sources treat RA like a totally different beast.
It is. With rheumatoid arthritis, the immune system skips the fat cells entirely and directly attacks the joint on its own.
Wow.
RA is an autoimmune disease from day one. Your immune system makes this profound targeting error and misidentifies the delicate lining of your joint, the synovium, as a foreign invader.
So white blood cells just flood the joint lining like they're fighting an infection.
Yep. And that chronic severe inflammation causes the synovium to mutate into this abnormal, aggressive tissue called pannus.
Pannus. The sources mention this tissue physically invades the bone, but how does a soft tissue destroy a hard bone?
Think of pannus like aggressive ivy growing over a brick wall.
Okay.
It doesn't just sit on the surface. The pannus tissue secretes enzymes that dissolve the cartilage, And it actually stimulates those demolition cells we talked about earlier.
The osteoclasts.
Right, the osteoclasts. It stimulates them to start eating the bone right at the edge of the joint. It digs its roots into the mortar and dissolves the architecture.
That sounds devastating.
It is. Without treatment, RA rapidly causes symmetric joint destruction, where the fingers might bend outward sharply or the joints fuse together entirely into a solid mass of bone.
Unbelievable. Now, before we move on to how doctors figured all this out historically, I have to ask about a famous piece of joint mythology in the sources.
Let me guess. The knuckle cracking warning.
Yes. Everyone's mother told them that cracking their knuckles would cause arthritis by grinding the joints down.
The ultimate parental threat.
Right. But there is a fantastic piece of medical lore that puts this to rest, courtesy of a physician named Donald Unger.
I love this story.
It's so good. Unger wanted to test his mother's warning, so he designed a literal lifelong self-experiment. For over 60 years, he cracked the knuckles on his left hand at least twice a day, and he completely abstained from cracking the knuckles on his right hand.
I mean, it's a sample size of one, but a remarkably controlled longitudinal study.
Yeah, and after 6 decades, he imaged both hands. There was absolutely zero difference in arthritis development between the cracked hand and the uncracked hand.
None. And larger modern studies have backed him up. The popping sound is just gas bubbles bursting in the synovial fluid. It does not damage the cartilage.
So he proved his mother wrong and won an Ig Nobel Prize for it in 2009. But it raises a bigger question for me. If the mechanisms behind these diseases are so radically different, a silent imbalance of bone remodeling versus an autoimmune IV destroying the joint, how did doctors historically ever figure out how to separate and categorize them? Like before they had modern lab tests or imaging.
Well, the initial discoveries were heavily reliant on autopsy.
Oh, grim.
Yeah. The word osteoporosis itself was coined by a French pathologist named Jean Lobstein in the 1830s. He was sawing bones open in a morgue and noticed that some of them had these massive empty pores. They looked like sponges.
So he just called it osteoporous porous bone.
Exactly.
But that was just a visual label for dead tissue, right? It doesn't explain how the disease works in a living person.
Right, and it remained a passive anatomical curiosity for over a century. The leap to an active clinical diagnosis didn't happen until the 1940s at Massachusetts General Hospital.
Okay, what happened then?
An endocrinologist named Fuller Albright made the connection between postmenopausal bone loss and estrogen deficiency. Albright figured out the Foreman mechanism we talked about earlier.
He did. He proved this wasn't just an inevitable fuzzy feature of getting old. By linking it to a specific hormonal drop, he turned a morgue observation into a treatable hypothesis. He is essentially the father of modern osteoporosis medicine.
Okay, so that separates out the bone density issue. But what about the arthritis umbrella? The sources note that the term arthritis goes all the way back to Hippocrates, using it as a catch-all for joint pain. How did we eventually carve rheumatoid arthritis out from everything else?
That breakthrough required a technological leap in 1859 by a British physician named Alfred Baring-Garrod.
Garrod.
Right. At the time, doctors dumped almost all severe joint pain into a single diagnostic bucket called gout. But Garrod developed one of the first reliable blood tests for uric acid.
Uric acid being the chemical that crystallizes in the joints of people who actually have gout.
Correct. So Garrod took a huge ward of patients who were all diagnosed with gout, and he ran his new blood test.
And what did he find? He found that one group indeed had highly elevated uric acid. But there was a second group patients who mostly suffered from symmetric, progressive destruction of the small joints in their hands who had totally normal uric acid levels.
So by proving they definitively did not have gout, he realized he was looking at an entirely separate disease.
Exactly. He took that uric acid negative group and officially named their condition rheumatoid arthritis. It was the founding act of modern arthritis classification, relying on a chemical biomarker rather than just looking at symptoms.
Here's where it gets really interesting, though. We go from Garrod using a rudimentary blood test in 1859 to the incredibly sophisticated metrics we use today. But our sources suggest that sometimes relying too heavily on modern numbers creates its own set of problems.
It definitely can.
Let's talk about the diagnostic standard for osteoporosis today, the T-score.
Right. So since standard x-rays miss early bone loss, we use a DXA scan, a dual energy X-ray absorbed geometry scan. Yeah. It shoots 2 different X-ray beams through the bone, and by measuring how much energy gets absorbed, it calculates your bone mineral density.
And the World Health Organization took that density metric in 1994 and created a hard cutoff. If your T-score is negative 2.5 or lower, you officially have osteoporosis,
Yes.
which means your bone density is 2.5 standard deviations below the average peak mass of a healthy 30-year-old. I mean, it sounds very precise.
It sounds mathematically objective, but it contains a massive flaw.
Which is?
Well, the WHO originally built that negative 2.5 threshold for epidemiology. It was a tool designed to compare fracture rates across populations of thousands of people in research studies. It was never intended to be a hard and fast diagnostic rule for an individual patient sitting in an exam room.
Because, as we touched on earlier, a density number doesn't tell you about the quality of the bone.
Exactly. The DXA scan tells you the raw quantity of bone mineral, but it tells you nothing about the microarchitecture. Like, are the tiny structural struts inside the bone well connected, or are they disconnected and fragile? Two patients can have the exact same T-score of negative 2.5, but face vastly different real-world risks of actually snapping a bone.
So if the T-score is flawed, how is a doctor supposed to know who is actually going to fracture?
The medical community realized this gap, and a researcher named John Canis, who ironically helped set that original WHO cutoff, he later led the development of the FRAX tool.
FRAX.
Right. It's an algorithm that forces clinicians to add context. You plug in the T-score, sure, but you also input clinical risk factors. Do you smoke? Do you use oral steroids? Have your parents ever broken a hip?
So it looks at the whole picture.
Exactly. The tool calculates a 10-year probability of a major fracture. It shifts the diagnosis from a simple density number to a holistic risk assessment.
That context seems especially critical when dealing with osteopenia.
Oh, yes. Osteopenia.
Right, which is that intermediate zone. Your T-score is between negative 1.0 and negative 2.5. So your bones are thinner than a 30-year-old's, but you don't hit the osteoporosis cutoff. Some of the sources frame osteopenia as a helpful early warning system, but others are fiercely critical of it.
Very critical. The critics argue that we have essentially medicalized normal aging.
How so?
By labeling millions of people with osteopenia, we are telling individuals whose actual risk of fracture might be incredibly low that they have a pre-disease. It generates immense anxiety and can lead to unnecessary medication.
And speaking of medication, treating these conditions has a wildly complicated history of miracles and disasters.
You're really good.
Let's look at the arthritis side first, because we actually figured out how to intercept that immune system attack.
We did. And it is one of the greatest triumphs in modern rheumatology. The introduction of biologic drugs, specifically TNF inhibitors like etanercept in the late 1990s.
Walk me through the mechanism there. How does a biologic stop the panis ivy from destroying the joint?
To put it simply, TNF tumor necrosis factor is essentially the chemical flare gun that your immune system fires to call in an inflammatory attack.
Okay, the flare gun.
Right. Before biologics, doctors tried to broadly suppress the entire immune system, which was toxic and imprecise. But biologic drugs are engineered proteins that circulate in the blood and literally bind to the TNF molecules. They intercept the flare gun in midair before the rest of the immune system can even see the signal.
So the attack gets called off before it starts.
Exactly. That takes a disease that used to guarantee visible deformity and disability and turns it into something you can often drive into complete remission.
That is a true medical miracle. But on the flip side, trying to medicate these complex pathways has also led to catastrophes. The Vioxx disaster of 2004 comes to mind from the sources.
Vioxx is the ultimate cautionary tale. It was designed to treat osteoarthritis pain by blocking an enzyme called KEOX2, which promotes inflammation.
Okay.
Older painkillers blocked KEOX2, but they also blocked KEOX1, which is an enzyme that protects your stomach lining. That's why heavy ibuprofen use causes gastrointestinal bleeding.
Right, so Vioxx was engineered to only block the inflammation enzyme, sparing the stomach. I mean, it sounds perfect.
It was perfect for the stomach. But by selectively blocking KEOX2, the drug completely threw off the chemical balance in the bloodstream that regulates clotting.
Oh, no.
Merck had to pull Vioxx from the market because long-term use caused a catastrophic elevation in blood clots, leading to tens of thousands of heart attacks and strokes.
Jeez. It solved a bleeding problem by creating a fatal cardiovascular problem.
Exactly.
And the osteoporosis field had a drug scare of its own, but the fallout was entirely different. The frontline medications for osteoporosis are bisphosphonates.
Yes.
How do they actually fortify the bone?
Bisphosphonates are fascinating. You ingest them, and they actually embed themselves directly into the bone matrix. When the demolition crew, the osteoclasts, come along and try to eat the bone, they ingest the bisphosphonate.
Oh, what happens?
The drug then essentially poisons the osteoclast, forcing the cell to undergo apoptosis, or cell death.
Wait, they literally poison the cell.
Yeah, they kill off the demolition crew. And by doing that, the builders are allowed to catch up and thicken the bone.
It sounds incredibly effective at stopping bone loss, but the media latched onto two extremely rare side effects.
Right. Atypical femur fractures and osteonecrosis of the jaw.
The jaw issue is particularly visceral.
It is. Because your jaw undergoes constant microtrauma from chewing, it needs high levels of remodeling to heal. If you completely freeze the remodeling process with powerful bisphosphonates for too long, the jawbone can literally die and become exposed.
Wow. Now, the sources emphasize that these side effects are exceedingly rare, like winning a terrible lottery. But the media coverage was so intense that prescribing rates plummeted worldwide.
Patients were terrified to take the medication, and doctors were hesitant to prescribe it. And the tragic irony is that multiple health systems tracked what happened next.
What happened?
Because millions of people stopped taking highly effective bone-fortifying medication to avoid a 1 in a million jaw issue, there was a measurable, massive spike in fatal hip fractures.
The fear of the side effect produced vastly more death and disability than the side effect itself. So, synthesizing all of this, the silent bone loss, the chemical arthritis, the diagnostic tools, what does this mean for you, the listener? Why does having this exact vocabulary matter for your future?
It matters because of a compounding condition called osteosarcopenia.
Osteosarcopenia.
Right. Sarcopenia is the age-related loss of muscle mass and strength. If you combine weak, deteriorating muscles, which vastly increase your risk of falling over, with osteoporosis, which means your skeleton is too fragile to survive an impact, you get osteosarcopenia.
It's the worst possible combination of vulnerabilities.
That specific combination is the primary driver of nursing home admissions. It is very often not a heart attack or a stroke that strips an older adult of their independence. It is a fall and a fracture that they cannot recover from.
And we absolutely have to debunk the demographic myth here. This is not just a disease of postmenopausal women.
Not at all.
Up to 1 in 4 men over the age of 50 will experience an osteoporosis-related fracture. But because public awareness and screening guidelines skew so heavily toward women, until they break a hip.
And younger people can develop secondary osteoporosis from long-term steroid use or eating disorders. Assuming that only older women need to worry about bone density leaves a huge portion of the population exposed.
As we wrap up this deep dive, I want to leave you with one final thought to mull over, circling back to that counterintuitive fact we opened with. We discussed how, in osteoarthritis, the fat tissue around our joints isn't just passive weight, it is actively secreting inflammatory adipokines that degrade the cartilage in our hands.
The systemic chemical warfare.
Right. If that is true, if fat is sending targeted chemical signals to destroy joints it doesn't even touch, should we stop thinking of obesity entirely as a physical weight issue?
It's a profound question.
The mechanics of gravity might be the least of our problems. Should we start viewing body fat as a rogue endocrine organ? An organ that actively dictates the degradation of our skeleton from the inside out. It completely shifts how you view the architecture of your own body. So the next time someone writes off a twinge or a break as just old person joint problems, you'll know exactly how much complex, silent, and chemical warfare is actually happening beneath the surface. Thanks for joining us on this deep dive, and keep questioning the labels we use for our own bodies.